Lastly, for the trauma section, I want to cover some basic thoracic trauma and how to treat it, because thoracic trauma is something that can quickly cause a patient to die, and it could frequently be missed. So start off flail chest. What is a flail chest? You typically get 3, maybe more segments of rib that are rib segments that are fractured, and as the patient inhales, they create negative intrathoracic pressure. They inhale, and then that flail segment goes inward. So it can cause hypoventilation by not allowing the lung to properly expand. In the past, we would treat this with, you'd put some pressure on it. We thought that helped, but it can actually make it worse. Some places even used to put sandbags on victims' chest. Not effective. So how do you treat it? You treat it with pain relief, supplemental oxygen, and surprisingly, the best way to treat it is to splint it from within with positive pressure. And if the patient's in severe distress, it sounds weird to say that you could treat a chest trauma with CPAP, but you can. You can also treat pulmonary contusion with CPAP. Think of pulmonary edema, but in this case, there's just blood in the alveolar space from chest trauma. So it's kind of like pulmonary edema. The management is supplemental oxygen and CPAP. But be advised that if you give too much oxygen, if you give too much fluid to these patients, then you can worsen the edema, make ventilation and oxygenation worse. Open pneumothorax, that's basically just a sucking chest wound. When the patient has this large wound in their chest as a result of a stab wound, gunshot wound, there's communication between the environment and the pleural space. And air wants to follow the path of least resistance. So as the patient's inhaling through their mouth, air may come in through that wound, that open communication, and make their ventilation ineffective. Now, something that's pretty interesting is this could create a one-way valve if there is a flap still present. So if you do a finger thoracostomy, which we're not doing at the time of this recording, and there's a flap, you might not necessarily need to seal that because it kind of can create a one-way valve. What makes it a sucking chest wound? Well, you hear audible noise as air travels in and out of the hole in the chest wall, and you can see some bubbling right there. So how do you treat this? Well, you treat it with an occlusive dressing. Now, it's debatable, should we tape it on all 4 sides? Well, it might not be that important, we've come to find out. But in general, we want air to be able to escape but not get in. So we use commercial chest seals, so like Asherman chest seals that allow air to get out but not in. Now, attention pneumothorax may develop regardless of the type of chest seal that you're using. So, and if there's damage to the underlying lung, then definitely a pneumothorax is possibly going to be present, and it is possible that that wound can collapse, seal itself, or the patient could have a pneumothorax in a different part of the lung, and it might not escape from that section, so you may still need to decompress. Tension pneumothorax, we have an entire training on pneumothorax and needle decompression, but I do want to reiterate that in a spontaneously breathing patient, usually the first signs that you will see is hypoxia. They start off with hypoxia that progresses, and it becomes progressively worse until they go into respiratory failure. So in a spontaneously breathing patient with a pneumothorax, respiratory failure usually precedes hemodynamic compromise. So you could have a patient with tension physiology without the classic obstructive signs that you expect to see, like JVD, tracheal deviation, hypotension, things like that. Now, if a patient is breathing spontaneously, or even if they're not, but they have a pneumothorax, it might not be readily apparent, but once you ventilate them with positive pressure, they can decompensate rapidly. So we should consider a tension pneumothorax anytime you have a patient that decompensates immediately after you provide positive pressure ventilation, whether they have an I-gel, an ET tube, or just old-fashioned BVM ventilation. Tracheal deviation, we talk about it a lot, but it's a very, very late sign, not always present, and it usually means that the patient has impending arrest. A good sign that you can identify early on is unequal chest rise and fall, but it can be hard to pick up on. You have to look you have to step back a little bit, look from the head of the stretcher or the feet, and look at the body kind of that way, and you can observe subtle changes because one side of the chest is falling rising and falling more effectively than the other. And of course, we know all of the treatment: needle thoracostomy, anterior axillary line, and that's the main treatment. Cardiac tamponade. So this is pretty interesting, and it's something that we can't do a whole lot about. So it's important to be able to pick up on this so that you know that you need to get to the patient to definitive care. And the definitive care is not in the back of an ambulance. It's in a facility that can perform a pericardial centesis. And this can be life-saving, really life-saving. Because fluid accumulates rapidly in the pericardial sac, and with each contraction of the heart, more blood can enter. And they either usually present with PEA or they rapidly decompensate with PEA. Now, you can get cardiac tamponade from medical causes, from fluid filling the heart. So it's not useful just for trauma, but also for medical. Now, if you have a stab wound that's anywhere in like a cardiac box in the general vicinity of the heart, you should consider that the patient could have a cardiac tamponade. And the cardiac box is also on the back as well. What signs and symptoms do we expect to see? Well, we look for Beck's triad. What is Beck's triad? Usually muffled heart sounds, jugular venous distension because the blood can't get back to the heart, it's filling up, and low blood pressure. They can also have pulsus paradoxus, which is when the patient takes a breath, the blood pressure drops. And I think it's like somewhere from 10 to 20 millimeters of mercury. The treatment is IV and fluid and O2. Now, this is a situation where we kind of just have to give lots of fluid if we suspect that this is happening. Commotio or commotio cordis. This usually occurs in athletes or in anyone where there is an innocuous or discrete blow precipitating sudden cardiac arrest. They get hit in the anterior part of the chest with a fist, a baseball, a bat, a lacrosse ball, or something like that. And it can seem pretty minor, and it's usually not penetrating. And the actual the patho behind this is honestly not well known. We usually teach people that, well, it usually occurs from R-on-T phenomenon. You convert mechanical energy to electrical energy. Think of precordial thump, like that. We convert mechanical energy to electrical energy. But it also, coronary artery vasospasm from the blow that occurs from the blow could play a role as well. So how do we treat this? Well, we kind of treat it similar to other sudden cardiac arrest, with an emphasis of getting the pads on as soon as possible and providing defibrillation. It is important to note that athletes that have some genetic predisposition to channelopathies, maybe they have prolonged QT syndrome or Brugada syndrome, they can go into sudden cardiac arrest, and typically what we should do, any athlete that collapses suddenly while exerting themselves should be presumed to have collapsed from a sudden cardiac arrest until proven otherwise, because we don't associate sudden cardiac arrest with young, healthy people that are involved in activities, but it is actually more common than we think. Tracheobronchial disruption is something that is uncommon, but it's highly lethal, and there usually results from a tear somewhere around the carina, and you get massive volume of air leak into the pleural space or the mediastinum. So you can get a tension pneumothorax or pneumomediastinum. And these patients are obviously in severe distress. They're very diaphoretic and they have severe respiratory distress. And you can get massive amounts of subcutaneous emphysema from this. How do you treat it? You give them oxygen, you decompress. Another treatment is selective main stem intubation. So you could perform this easily if you, one, knew that they had a tracheobronchial disruption, and two, the tracheobronchial disruption occurred on the left side, because then it would be much easier to selectively main stem intubate the right main stem with the equipment that we have. Now, if you want to read the words on the right, the paragraph on the right, it was an interesting case study where a patient had a fall and was taken to a tertiary facility, not like a trauma center, and they placed a chest tube, took him to the trauma center, and they didn't initially appreciate that the patient had a tracheobronchial disruption, but a key finding here was that, well, they had a lot of sub-Q emphysema, and there was continuous air bubbling noted in the pleural drainage. Now, if you've been taught how to troubleshoot a chest tube and a pleural drain, you know that usually continuous bubbling is caused by a leak in the system. Well, that leak could be from a tracheobronchial disruption if you have properly troubleshooted the rest of the system. Traumatic asphyxia is pretty interesting. It's like it presents as other other strangulation patients would, or strangulation cases would. They get like this bluish discoloration of the face or neck, but it's not true asphyxia. The actual pathophysiology is due to an increase in thoracic pressure. So imagine a car falling on top of a patient's chest. It forces the blood back out of the heart retrogradely in the direction it's not supposed to flow, back into the patient's like head, neck, and chest area. It usually doesn't show up in the extremities because the veins of the neck and the head lack valves that are present in the extremities. How do we treat it? It is usually supportive. Diaphragmatic rupture, which is, I think, another probably uncommon. So anytime you have a laceration in the diaphragm, abdominal contents can herniate into the chest cavity. Anytime you have a penetration below the level of the nipples or the level of the scapular tip, you should suspect a diaphragmatic rupture. Why the level of the nipples? Well, because when the patient exhales and the diaphragm contracts from here to up here, it can go up to the level of the nipples. So anywhere from basically the level of the nipples down, you should suspect a diaphragmatic rupture. Now, usually if it's penetrating, it's going to be small, but if it's a rupture due to blunt trauma, then abdominal contents in the stomach can actually herniate into the chest wall. How do they present? Well, there's usually like a contusion to the chest. History is key here. They may have subcutaneous emphysema, and it may present like a pneumothorax. You can have decreased breath sounds on one side, and decompressing the chest isn't going to help a whole lot here. So you may want to consider the history and really auscultate the breath sounds to see if you hear any bowel sounds over the chest before you decompress. The abdomen also may have a scaphoid appearance. How do we treat this? Well, just supplemental O2, rapid transport, and if you have ventilated the patient, they could have a lot of air in their stomach, which could further fill their chest, and decompressing the stomach could be helpful here. Trauma in pregnancy, it is important to note the physiological changes that are associated with pregnancy. So, because as the woman progresses in pregnancy, their cardiac output increases by 1 to 1.5 liters per minute, which means since they have a larger blood volume, they could lose a lot of volume before they have any signs and symptoms of hypovolemia. Also, hypovolemic shock can induce premature labor because when the pregnant patient loses circulating blood volume, oxytocin and ADH can be released, which stimulates uterine contractions. Supine hypotension syndrome, or just supine hypotension is a major concern in the patient with third trimester pregnancy, or anytime they have a gravid uterus, because when they lay flat, the gravid uterus can compress the venous return back to the heart, causing a decrease in cardiac filling and hypotension. Also, when you have a pregnant patient that is eclamptic, it can mimic TBI. So if you have a pregnant patient that was involved in an accident, you might need to differentiate between TBI and eclampsia, because traumatic brain injury can cause seizures and it can cause hypertension. So how do we treat supine hypotension syndrome? Well, if they're mobilized, which you can get them off the backboard, but if they are mobilized, then you put padding under the right side of the board, about 4 to 6 inches, just to bring the abdomen or the uterus to the left a little bit off the inferior vena cava. If you can't do that, then you can elevate the right leg, which could displace the uterus to the left. If they're in cardiac arrest and you need to do CPR, this is also true for just regular cardiac arrest in a pregnant patient. You can manually displace it, but you have to hold it. You have to assign somebody to manually displace the uterus to the left. Now, if a pregnant patient is in cardiac arrest, then we should perform all meaningful interventions during transport. This is a load and go situation, because this can an emergency cesarean at a trauma center can be life-saving. Very few other facilities are unlikely to perform an emergency cesarean as quickly and effectively as a trauma center is. Now we're going to cover musculoskeletal trauma. So if a patient has trauma to a limb, they can lose a significant amount of blood volume, circulating blood volume. This could be due to damage from the blood vessels themselves, due to fractured bones, muscles damage. Additionally, the swelling that results from this could result in a cold, pale, pulseless extremity, and they could become pulseless not just from the swelling or compartment syndrome, but also from disruption in the blood flow to that extremity due to damage from the arteries themselves. Now, the thigh and the pelvis, damage to either of these compartments can result in massive blood volume, and the patient could actually go into hemorrhagic shock or lose almost all of their circulating blood volume if the injuries are in these places. There is a specific device created for this, right? There's a device created for femur fractures. It's a traction splint. it's a good device. Now, there's not great data on it, but it just makes good physiologic sense that straightening long bones and applying traction to them can be beneficial for the patient for a number of reasons. We also have a pelvic device, pelvic binder that is created or that is designed so that if there's an open book pelvis, we can close that to decrease the space in which blood can accumulate in. And as a general rule for managing extremity fractures, if there is an absence of a pulse in that extremity, or if there's a deformity in that extremity and you don't have a pulse, you should attempt to realign the limb. And it is just good practice. It's a good rule of thumb in general to make limbs look like limbs. And typically, if we have a code, pulseless extremity, we can make up to 2 attempts to realignment. Now, historically, they say that if you feel a lot of resistance when you try to realign the extremity to stop, you're probably going to feel some resistance. And we're kind of like, when we do this, we're like gentle about it. And if you've ever seen anyone try to realign an extremity or reduce a fracture, there's not much gentle about it. So it should be that it shouldn't be if you meet resistance. It should be if you meet significant resistance when trying to realign an extremity. General fracture management consists of, first of all, assuming that any wound or laceration or puncture overlying the area of a fracture, assume that that is an open fracture until proven otherwise. Yeah, of course, it could be that they fell and then they cut their extremity on something and then they obtain a fracture. But either way, it's still an open wound overlying a fracture that is prone to infection. All right, there's a significant risk of infection. So how do we treat that? Of course, you cover the wound with a sterile dressing. Usually you moist it with sterile saline or water, sterile water, and you put that over the end to try to prevent it from becoming contaminated. Now, realigning, even if it's an open fracture, realigning an extremity that is deformed makes it easier to splint, provides pain control, and it stabilizes the fracture. And even if you feel a pulse in that extremity, it still doesn't mean that the perfusion is great. So it could still restore perfusion to that extremity. Now, of course, before you reduce a fracture, you want to irrigate it thoroughly. And we'll talk about irrigation later. Is it a big concern if you try to realign it, there's a bone sticking out and it slips back in? Not really, because they're going to get irrigation and debridement in the OR, and of course they're going to get antibiotics. And as a good rule of thumb, limit your attempts to realign a fracture to 2. So how do you realign a fracture? Well, if you see this sticking out and I just pull on the leg, just pull it straight out, it's probably not going to do a great job of realigning, because if it's like this and I'm pulling in that same direction, right, then it's just going to hit the bone ends in the muscle. What you want to do, whatever direction the bone is whatever direction the bone is in, you want to pull in that direction so that you pull it out and then realign it. That's just general fraction realignment. Compartment syndrome could be a life-threatening, limb-threatening condition for that extremity. So what is compartment syndrome? Well, your muscles, the muscles in your extremity are enveloped by this connective tissue called fascia. Fascia does not stretch very well. Anything bleeding, swelling can increase pressure in that compartment, and increasing pressure in that compartment can cause what we refer to as compartment syndrome. Now, there are tools in the hospital that they use for measuring pressures in those compartments. But classic signs of compartment syndrome are pulselessness, pallor, and paralysis. These are late findings, but if you suspect this at all, you need to get them to the appropriate facility, and you can reduce tight splints to make sure that the skin and fascia and everything can expand. Elevate the extremity just to the level of the heart. Repeat as needed. These patients need a fasciotomy where they go in and cut down and allow it to expand and relieve that pressure. How do we manage amputations? Well, we wrap the amputated part in sterile gauze, moisten it with saline, and we put it in a plastic bag or container. We want something cool in there to keep the amputated part cool, but we don't want it to directly touch that ice or whatever cooling medium we're using it, because we don't want it to freeze. So just make sure it doesn't touch that. Crush syndrome is something that we treat very infrequently, but it's not something that we will never see, because we can get similar pathophysiology of crush syndrome from patients that are elderly who have fallen and can't get up, and especially the patient that has fallen in a bathroom and they become wedged next to a bathtub and toilet. There's a lot of memes about this, right? Every patient that falls in a bathroom, they're going to fall specifically in between the bathtub and the toilet. And of course, we loathe that the bathtubs are always right next to the toilet, and there is always just enough space for someone to get wedged in between there. But they could have a life-threatening condition, and it's not infrequently that we respond to patients who have been laying on the floor for an extended amount of time that can present with crush syndrome pathophysiology. So what is crush syndrome? Well, imagine a patient that is crushed, extremities, whatever, portions of their body are crushed. The pressure causes the death of muscle, which releases myoglobin. When muscle tissues are damaged, it releases myoglobin. Myoglobin is bad for the kidneys. It can cause renal failure and damage organs, and it can also cause death. When cells are damaged, they release potassium. Now, it's generally not a concern while that person remains in that position, whatever position they're crushed in. Once you release that, the reperfusion allows the blood with the elevated levels of myoglobin and potassium to wash out of the injured area into the rest of the body. This elevation in potassium can result in life-threatening cardiac arrhythmias. We all know what hyperkalemia is. That's what it causes. When that myoglobin gets released, it can produce tea or cola-colored urine, which can eventually result in renal failure. So, looking at a patient's urine, if they have to go to the bathroom or if they urinate on themselves, it can provide some useful information. So how do we treat this? Well, the goal is to resuscitate before extrication. And, most of the stuff that we talk about is resuscitate before you intubate, resuscitate before extrication. If you delay fluid resuscitation, 50% of the patients will have renal failure. And if you fail to improperly resuscitate them before they are released, they may go into cardiac arrest during the extrication process. So we want to give that initial fluid resuscitation, and then we continue a fluid drip or maintenance during transport. Now you can add 50 milliequivalents of sodium bicarb to a liter of fluid to alkalize the blood and the urine. Now, once you restore blood pressure and volume, you need to have the patient on a cardiac monitor to monitor them for hyperkalemia. And if you see widening QRS complexes, peak T waves, loss of P wave amplitude, or maybe even just a sine wave pattern. If you don't know what sine wave pattern is, look it up. It is where you can't differentiate basically between the QRS and the T wave. Your treatment for this includes standard treatment for hyperkalemia, which is sodium bicarbonate, beta agonist, and IV calcium chloride. The albuterol or beta agonists help shift potassium from extracellular to intracellular, and calcium chloride stabilizes the myocardial membrane. Sprains are commonly encountered in the pre-hospital environment, especially if we're working special events or if we go to the gorge to help rescue someone. And it can be helpful to know if someone has a sprain versus has an actual fracture. This is the Ottawa ankle rules were developed to help physicians decide who needs an x-ray and who doesn't. So basically it helps differentiate between who has a sprain and who has an actual fracture that would warrant x-rays. And if it's good enough for determining if a patient has a fracture or not, or if they need x-rays or not, then it's generally good enough to use for other things. We do this with the Canadian C-spine rules and so forth, and the nexus criteria. But basically, if you look at this image, there are zones, midfoot zones, malleolar zones here, and the edge or tip of the lateral malleosus here. Usually if a patient has bone tenderness at A, B, C, or D, depending on which side you're looking at, they need an x-ray and they should not bear weight in that zone. Also, if they cannot bear weight immediately when you get there, then they likely have a fracture and not a sprain. Now, why is this useful? Well, maybe they're in a situation where you actually need them to ambulate, where it would be safer for them to walk than for you to carry them out. That is something to take into consideration. Basic wound management. We need to define wounds. We need to differentiate between clean wounds, dirty wounds, and contaminated wounds. Clean is a simple wound in an area with a low bacterial count, so not in the axilla, not in the groin, that was treated or irrigated shortly after the wound occurred. And a simple wound is considered something produced by a blade. Dirty would be in a bad area with a high bacterial count, so axilla, groin, or they present late, and presenting late allows the bacterial count to increase, or it could just be a grossly impregnated wound, a wound impregnated grossly with like soil, fecal matter, or something that's presenting signs of infections. That would be a contaminated wound. So this chart will help you decide if a patient needs tetanus prophylaxis or not, and it's based on the history of immunization. All right. So if someone gets a laceration, they're like, should I go to the hospital? Should I not? We say, well, you might need a tetanus vaccine. Or we say, have you had a tetanus vaccine? Well, even if they have had a tetanus vaccine, even if they've had, look at this here, even if they've had 3 or more within the past 10 years, but there is but it's a contaminated wound, then they could still need prophylaxis. But if it's a clean minor wound, in most cases, they're not going to need prophylaxis unless they don't know their immunization history or it's been more than 10 years. So this is useful for you to maybe take a screenshot or take a picture of in case you are treating a patient. How do we irrigate and clean wounds? Well, we consider a low volume, less than a liter, and a high volume of irrigation, more than a liter. High pressure irrigation can be generated usually by placing a IV catheter on a syringe and pushing that syringe. And low pressure would be like taking a bulb syringe or punching a hole in a bag of fluid or a container. So how much pressure and how much volume do you need? And I'm not going to read through all of this. There's a lot of literature looking at the infection risk based on how much volume you use and how much pressure. So here's a summary. To properly irrigate a wound, you generally need about a liter of irrigant under high pressure. Now there's some literature arguing that you don't necessarily need high pressure, you might just need a lot of volume. Because if you use too high of a pressure, you can push the bacteria further in the wound, and you can cause damage. So we generally, there is another like pressure level, which is very high pressure. So generally you'll want high volume and high pressure. But I think the most important thing we can take back from learning about proper wound irrigation is that if you do something, if you try to actually use a good volume under some pressure as opposed to just kind of taking a little 10 cc flush, squirting it on the wound, that it can make a big difference and decrease that patient's infection risk. I'm talking about purposeful irrigation of that wound, getting just good sterile water or saline in that wound to try to flush it out before you put a bandage on it. Now obviously if there's a lot of bleeding and there's severe hemorrhage, then that's going to take priority. But in many cases we can just focus on good wound care and good wound irrigation. And I know that this isn't something that we do frequently, but if a patient doesn't need emergent transport, take the time on scene and properly irrigate that wound. And that is all I have, and I hope this was helpful. If you all have any questions, please let me know. Thanks.